All right. Hello, everybody, and welcome to today's Cannabis Scienza LinkedIn Live event with a very special guest today to discuss medical cannabis in pain therapy. Uh, I'm tuning in, by the way, from the Cannabis conference in Freiburg, Germany. So, shout out to Cannabis. Great event here today. And we are certainly extremely excited to have our guest with us as well. I'm personally very excited about the questions we're going to be asking. And as always, a big thank you to all of you that have, registered to attend. Big thank you to the audience with us right now at the moment, and thank you to everyone that will tune in the future. Uh, I'm going to pass the mic over to my friend and colleague Fabio Turco, CSO of Cannabis Scienza, and please give our guest a warm welcome, Fabio.
Thank you, Bijan. Good afternoon to everyone. And also from my side, welcome back to Cannabis Scienza live on LinkedIn. This week's topic focuses on medical cannabis and pain management. And in my opinion, it's an extremely relevant argument since possibly pain and especially chronic pain is one of cannabis' most important application. And for this, it's a great pleasure for us to talk with our guest, that is Professor Livio Luongo, pharmacologist from the Vanvitelli University of Naples in Italy, whose research focuses primarily on pain and also on endocannabinoid system. So, good afternoon, Professor Luongo.
Good afternoon to everyone. Thanks, Fabio. Thanks, Bijan, and thanks, Cannabis Scienza, for this invitation, kind invitation. And of course, all the attendees for their patience to listen to me today.
Okay, we have a lot of questions for you, but before starting, I would like to remember that Professor Luongo works with Professor Sabatino Maione, that is one of the most important Italian pharmacologists. And moreover, Professor Luongo has collaborated with the leading experts in the field of medical cannabis, such as Raphael Mishulam, Roger Pertwee, and Vincenzo Di Marzo. So, let's start with the topic that is pain. And it's not easy to talk about pain. And defining pain can be difficult as well, because pain involves a lot of aspects. It involves psychological aspect, sensory aspect, and emotional aspect as well. So let's begin by asking Professor Luongo what pain is from the perspective of a pharmacologist.
Well, thank you, Fabio, for the question. This is a very brilliant question because, recently the International Association of Study of Pain redefined actually the pain, which is an unpleasant sensory and emotional experience, which is very personal. These two words, sensory and emotional, characterize the pain. So we cannot think about pain as a nociception. So it's not a sensorial, exclusively a sensorial aspect, but it's also associated with several emotional changes, and it's very personal. That's why we cannot measure pain. It's not like a blood pressure that you can have some numbers and you can say, okay, under 20 and 80 is okay, I'm a normal person. The problem with pain is this subjective, this personal experience. So this is a problem for the patient, but it's also a problem for the doctor, and it's also a problem for the clinical study, the clinical trials that we are basically analyzing every time, because pain is one of the most problematic affected by placebo effect, because of course this subjectivity of the pain give to the patients also a kind of trust in the medical doctor. So the medical doctor, when they spend a lot of time with patients, and these patients are actually also gratified, rewarded by the medical doctor. In this case, pain can be relieved also by placebo, and this is quite true as well. So pain, as a pharmacological point of view, is quite tricky because usually it's a symptom of several other pathologies. But when there is a chronification of pain, this becomes per se a real pathology and has to be treated with all the possible tools that we have, drugs, but also psychological support and several other things.
Okay, that's why also research into chronic pain and its treatment is very urgent. Also because the burden of disease is high. Indeed, according to some reports, 1 in 5 adults suffers from some form of chronic pain. So in this context, Professor Luongo, is cannabis effective against pain? And if it is, what type of pain does cannabis most effectively treat?
Yeah. Well, when we think about pain, we have to take in account that the most powerful analgesic are the opioids, of course. There is nothing which is more analgesic than opioids. The pain is different because we have several kinds of pain. We have acute pain, nociceptive pain, there's post-operative pain, post-surgery, for example. But we have chronic pain. We can have cancer pain, which has a mixed component. We can have neuropathic pain, which instead come from a lesion to the peripheral or central nervous system. So some of these kind of pain could be also refractory to opioids. I think, for example, neuropathic pain, this is one of the most refractory to the opioids as well. So it means that, you treat this kind of pain with drugs that are not analgesic drugs. So we treat neuropathic pain, for example, with anti-convulsant drugs, pregabalin, or antidepressant drugs, such as amitriptyline or duloxetine, something like this. So in terms of cannabis, and cannabinoids and cannabis-based medicine, what they found, is that there is some kind of pain in which cannabis could be quite relieving. For example, fibromyalgia. This kind of pain is called nociplastic pain. It does not derive from the lesion of the peripheral or central nervous system, for example, but this can also be induced by an early life stress. Imagine, for example, a rape or something like this, or the loss of some parents. So there is a very important idiopathic and psychological aspect associated with this kind of pain. And in this kind of pain, cannabis seems to work. But if we think about the cannabis and all the phytocannabinoids into the plant, we know that only THC is able to bind the CB1 and CB2 receptor. So it's the only one which is working definitely through cannabinoid system. All the other one, are working on several other neurotransmission, which in part are involved in pain. And another thing that we have to get in account is that when you do a clinical trial, for example, treating patients with cannabis, you don't have to think to the normal scales that we use, for example, when we are treating patients with the opioids. Okay, usually the clinical trials of pain, the first outcome is the numeric scale rate, because we say, how do you feel pain from 0 to 10? This is the scale. It's like to ask to my daughter how much you love me from 0 to 10. And it's very subjective, and it's also very difficult for the patient. It's very difficult to explain to the doctor the number of pain that is feeling. Imagine that I'm feeling low pain. I can say, okay, 1, 2 to the scale. Or very big pain, I can say 9. But how I can discriminate between 5, 6, and 7 is very difficult for the patients, but it's very difficult for the doctors as well. So, cannabis in this case, in this context, the cannabis is working because, not because it's working on the pain like opioids, not in the pain nephraxis, even if the receptors are expressed along the pain matrix. But, cannabis make distance between the patients and pain. So, pain demand attention, and cannabis distract from the pain sensation. So now people suffering from chronic pain, from neuropathic pain, they are living by expecting the moment during the day in which they will have electricity by, by doing this, what I'm doing now. So you do this, which is not painful sensation, and your brain perceived this movement like painful, very painful. So you become to be stressed and you expect this moment during the day. So when you use cannabis, it seems that this moment is not expected as usual. So this should be included in the questionnaire that are usually done and performed when clinicians do clinical trials. I'm not a clinician, as you know, but I'm basic pharmacologist. But I'm working a lot with the clinician that they are using cannabis, and all of them are the problem because several clinical trials, failed to found a real, effect of the cannabis, let's say.
Yes, it's a very brilliant answer. And yes, talking about clinical studies, I remember that few weeks ago I read a systematic review published by the group of Marian McDonald at the University of Portland on cannabinoids in chronic pain. It was a systematic review that collected various medical studies published in the past. And according to the authors, there is little evidence that cannabinoids are effective in treating chronic or neuropathic pain. And maybe you just answer to this question, but according to you, why medical clinical trials fail to
Yeah,
find
the reason
this?
the reason is what I was saying before. Is the problem is this one. When you start a clinical trial with a compound, first you have to see whether or not ethically you can use placebo. If you can use placebo, when you use placebo, now with pain is even worse. Because with pain the placebo effect is even worse. There is a great scientist in placebo and nocebo field, which is called Fabrizio Benedetti, Professor Fabrizio Benedetti from Turin. And they developed a new method to do pain clinical trials, in which on one arm, the pills is given by a computer, and on the other arm, the pills is given by doctors. And this is the real placebo, because it seems that if you treat with paracetamol, for example, paracetamol is an analgesic drugs which is used as anti-inflammatory drugs, but it's not really behaves as anti-inflammatory, but it's analgesic more than anti-inflammatory and antipyretic. So if the doctor give paracetamol to the patients, placebo is working. If the paracetamol is given by a computer, a machine, paracetamol lost this effect. So it means that we have a big placebo components, even if we know that placebo is used from probably everyone for several kind of moderate, low pain, not for severe pain. For severe pain, as I told you before, usually the doctors use opioids. So this could be one of the problem, and another problem is if we want to study well how the cannabis is working in pain, we have to think, at cannabis not as an analgesic drugs, but a drug that works on comorbidities associated with the chronic pain, which are psychological and psychiatric diseases such as depression, anxiety, hypocognitivity, and this kind of stuff. So in this, the attention to the pain. I told you before, the people suffering from chronic pain, neuropathic pain, they only think to pain. I experienced this in the last few days, and Fabio, I had the problem with my teeth, and you cannot concentrate because you are thinking to the pain every time. That's the problem. So how the cannabis does? The cannabis distracts you from the pain, but it is an analgesic. Not really. It's not like morphine, okay? It's not powerful as morphine. So why we use, and why sometimes it's working more than opioids in some pathologies? Because those pathologies are associated with several different pathways, including neuroinflammatory pathway, which involve several other cells into the spinal cord, into the brain, which are called microglia, in which opioids doesn't really work because worsen the situation of the neuroinflammation. But this is a very long and technical story that probably, okay, we can ask some technical question if you want, but it become quite difficult to explain in half an hour.
No, you've been really clear on this aspect, very important aspect to consider when it comes with clinical studies. Also, it comes into my mind that it's also difficult to blind patients to medical cannabis because the flavor, the smell is so typical that it's very difficult to blind the patient. So maybe this is also a reason why sometimes clinical studies fail to find to their primary outcome. Our company, Cannabis Scienza, is about to publish a handbook of clinical cannabinology in which cannabinoids are discussed in relation of different pathology and also in relation to chronic pain. So I would like to ask you, at the moment, the research in the field of medical cannabis and chronic pain focus mostly on THC, CBD, or the plant, or both.
Yeah.
What is it?
That's quite good question, because when we started in this, when we started, well, someone started before than me, of course, and I think the doctors that prescribe cannabis usually they prescribe cannabis with a content of THC, especially during the night, because this is also helpful, for getting sleep sometimes. Which the problem, there are several disturbances also in the sleep when you are in pain. It's like in depression and sleep, the brain works always or more or less in the same way. So we have to think about a common soil between several pathologies: so depression, neuropathic pain, and sometimes also, for example, metabolic diseases. It seems to have a common pathway downstream at the cellular level. So it's very complicated. The cannabis is what, yeah. I say every time, and you know that, and we we have to be precise where the compound into the cannabis can be used for specific pathology. We have to avoid that cannabis become a kind of panacea. So we have to know that the cannabidiol, for example, is working in epilepsy, specific kind of epilepsies, Dravet syndromes, Lennox-Gastaut syndromes, and so on. For example, in pain, in fibromyalgia, some fibromyalgic, usually women, are responsive to cannabis, and when they are responsive, they respond very well. The content of THC usually is higher during before to get asleep and lower in the morning. So I don't know if I can say the name of the strain of cannabis used, but usually, that one containing more or less 20% of THC I used during the night before to get asleep, and then that one containing half and half, or for example, low THC concentration and high cannabidiol concentration can be used during the day. There are several other problems related to the treatment of patients with cannabinoids or cannabis-based medicine. Can you drive when you use this one? No, you cannot drive after 24 hours. But if you do a chronic treatment, you cannot really drive every day. So there are a lot of lawyers, and of course and of course you will invite them to have a quite important discussion about this, because we have to put the patients also in a situation that they can go on with their own quality of life. They have to go to work and so on. So I think that when it's working, cannabis is a real good drug. And I know that we have to use evidence-based medicine, and I really hope that there will be in the literature quite good clinical trials as there have been in the past for other molecules. Because at the moment, I can say that now they are going to improve, but most of the clinical trials failed in some way. For example, in the stratification of patients, you cannot get all kind of pain. You cannot get neuropathic pain, for example, coming from diabetes, together with the neuropathic pain coming from chemotherapy-induced chronic neuropathic pain, or, for example, complex pain regional syndromes. They are completely different kind of pain. So we have first to stratify the pain, and then you have to choose the right one, and then you have to give the right strain of the cannabis in that patient. And this should be in a scientific way to do a clinical trial. Sorry.
Okay, thank you, Professor Luongo. You have been really exhaustive in your answer. Now let's talk about your work as a researcher, because I know that during the last few years, you and the group of Professor Cannazza have discovered 4 new phytocannabinoids compounds in the cannabis plant. So, can you tell us something about this discovery? Do these phytocannabinoids have any relevance to pain therapy?
Yeah, we had this chance to work together with Professor Giuseppe Gannazza from University of Modena. That 4 years ago we met almost 5 or 6 years ago, and then we started to collaborate, and we went on by trying to characterize some new minor cannabinoids into the plants. So he found several new compounds, in particular that one with the four carbon atoms in the radical chain lateral to the phenyl, which are called tetrahydrocannabinol, for example, butanoids. And then other two, which with six carbons. But the main probably discovered that he did, and well, we characterized, but he discovered this compound, which is called tetrahydrocannabiforol, which is able to bind CB1 receptors in a much more potently than THC, and also in vivo it seems to exert a tetrad behavior that I will explain soon, at 4 times more potent than THC. What does mean this? That when you inject THC, you have four behavior that you can measure. The first one is a hypothermia, the analgesia, the catalepsy, and the hypolocomotion. Okay, so if a drug which is cannabimimetic give these four behaviors, we can suppose which is working through the CB1 receptors. The CB1 receptors is that one expressed by the central nervous system, and that's that one which is also associated with the psychotropic effect of the THC, okay, in the plant. So we know that the CB1 receptors is that one involved in our brain, which is working in the brain. CB2 receptors is mostly involved in the inflammation, cope with the inflammation, reduce the neuroinflammatory process because it's expressed into the brain by microglia cells and so on. The THCP is quite potent, I would say, to inactivate these receptors, and is working. Well, the data that we have that we didn't publish yet about pain, but we are carrying on a very big studies in our lab, also in collaboration with other group around the world, in a different kind of neuropathic pain models, from peripheral neuropathic pain models and central neuropathic pain models. For example, that one induced by central thalamic hemorrhage, stroke, for example. And it is working at a really low dosages. At this dosages, it doesn't really exert any tetrad behavior. So this is quite interesting because probably is working on that receptors, which is not only expressed by the membrane. You know that the CB1 receptor could be expressed in the membrane, but also can be expressed in the mitochondria into the cells. This is the discovery by the group of Giovanni Marsicano in Saint Bordeaux, Pierre V. Piazza, and so on. So this is very complicated story, and we think that this molecule is going to be a quite interesting molecule. For now, it became a kind of a smart drug because it's out of the schedule, and of course you know that it's a psychotropic, and there was a problem about that anyway. But it's quite interesting also in terms of therapy. How much is present in plants? Very little. Okay, but the plants, the seed can be genotyping, and of course also we can also synthesize this compound. Nowadays we can also extract cannabinoids, pure cannabinoids from yeast, by engineering yeast. So we can do several things. So just a few seconds to say that remember that in the plants there are several phytocannabinoids, a lot of them. Very few of them are working on cannabinoids, receptors. Cannabidiol is working through pleiotropic mechanisms. It's working on adenosine, so by corroborating the purinergic system. It's working on the GABA, which is the the inhibitory transmitters in our brain. Is working in several others neurotransmission such as serotonin, but it's not working mainly on cannabinoids. Sorry.
Okay, thank you, Livio. But it's very interesting. But how do you feel to be the father of THCP? It's very
I'm
interesting.
not the father. Come on. We are not the father of everything. Professor Canazza, he could be defined the father.
You both are the fathers.
There is only one father of
down.
cannabinoids, as is called Professor Raphael Schulem, and
Yeah, I know.
all of you know. We are not at the same level of him, and we try to collaborate and participate in this FitFest, which is really exciting in terms of basic research, because the cannabinoid system is very ancient. It's one of the first transmission that we had. Also, unicellular alive bacteria, they have a cannabinoid system. This is because the endocannabinoid system is mainly involved in the energy storage and the energy balance. So we use for the storage of fat, for example, and this kind of stuff. Indeed, probably one of the main future direction is, of course, the cachexia, anorexia. Here, the cannabinoids are working very well, and no one can say that it's not working in increasing the appetite. So, of course, and this is very important in cancer patients. It's very important in AIDS patients, immunodepressive patients, and so on. So, in this case, it's very importantly used.
Okay, thank you, Professor Luongo. Maybe we have time for last question. And I would like to ask, we know that you are not a clinician, but according to your experience as a pharmacologist, what would you recommend to a medical doctor considering medical cannabis in chronic pain?
The first thing that usually when I talk with the clinicians is to say, stratify the patients, to see whether or not he's asking cannabis for which purpose he's asking cannabis, first of all. And because for several patients, the high effect induced by the THC is a side effect. So they don't want this one. Okay. So imagine, a female of 50 years old with the multiple sclerosis. She doesn't want the high effect induced by the THC. So basically, this is a side effect for her. But she is moving better because, with the spasticity, cannabinoids, they work very well. So she likes the feeling, but she doesn't want the dizziness and all the stuff that usually are, researched by the recreational use of cannabis. So the medical doctor has to tailor the therapy to the patients, because this is a galenic drug. We don't have the concentration. It's difficult. So they have to spend much more time with patients. And this is sometimes in some countries is a real problem. Imagine in China, in India, they spend three minutes per visit with the pain therapist. In China, 3 minutes. In Europe, more or less 6 minutes. If you go to acupuncturist, acupuncture, you spend 1 hour with patients, and that 1 hour is a placebo effect.
Yes. Thank you, Professor Luongo. I think it has been a very nice conversation about medical cannabis in chronic pain, and I give the speak to Bijan to conclude our event.
Yes, thank you, Fabio. Thank you, Professor Longo. Really awesome insights, and I hope we get to have you on again very soon. As we see, half an hour is never enough, regardless of what we're talking about in the space of cannabis. So, on that note, thank you to everybody for tuning in. Apologies for the slight technical difficulties. We will be back again next week. So if you're not following our page already, head over to Cannabis Science's LinkedIn page and hit that follow button. You can also see Professor Longo's profile linked on a few of our last posts. Definitely follow him and connect with him if you're interested in what we discussed today. Connect with Fabio, of course. He is always dropping gems and reviewing studies and publications. So keep an eye on us. We got some more exciting stuff on the way, and hopefully see you again soon, Livio. Thank you very much.
Okay. Thank you, guys, both of you. Thank you to
Thank you.
everyone. Bye-bye.
Goodbye. See you soon.
Goodbye.
Bye.
Ciao.